Thank you. Okay. Good morning, welcome, and thank you for joining us today for the meeting of the New York City Health and Hospital Equity, Diversity, and Inclusion Committee. Today's meeting is officially called to order. Next on the agenda, I would like to propose a motion to adopt the minutes of the Equity, Diversity, and Inclusion Committee meeting held on November 8, 2021. I will ask for each one of the members for their vote. Jose Pagan,
Yes.
Sally Hernandez Piñero.
Yes.
Okay. The resolution, I also vote yes. The resolution passes. Next is a diversity and inclusion update from Mathilde Roman. Mathilde,
Good morning.
good morning.
Next slide,
Good
please.
morning.
Morning.
So I just wanted to provide a brief overview of updates from the diversity and inclusion work that's been happening across the system. And so collectively, the top achievements for the system in 2021 include restructuring the health system strategic priorities to include social and racial equity as the foundation of its mission and values, creating system-level metrics to make equity, diversity, and inclusion goals more measurable and accountable. The 3 indicators being measured include the number of new physician hires from underrepresented groups, including race, ethnicity, and language values in chronic disease dashboards, and measuring the percentage of MWBE contracting spend. Next slide, please. I have it. Thank you. In 2021, the system launched the Medically Racism Initiative that was spearheaded by Dr. Lewis Hart from Quality and Safety, and now is under the Equity of Care Work Group within the Equity and Access Council. The health system also co-founded and is co-convener of the Citywide Coalition to End Racism in Clinical Algorithms. Dr. Davis, who is leading this effort, can provide further details when she gives her update. And the system neared its 30% contracting spend goal for minority and women-owned business enterprises. It's also worth noting that the system opened its 6th Pride Health Center, the first one in the Bronx, and Lincoln launched an affirming integrated service practice to provide affirming services to LGBTQ New Yorkers. The system continues to meet high standards of care for LGBTQ patients by earning the national recognition by the Human Rights Campaign for the sixth year in a row, and was profiled in the first national edition of the Long-Term Equality Index for promoting equitable and inclusive care for older LGBTQ residents in residential long-term care communities. To detail the progress made over the last 5 years, the Office of Diversity and Inclusion published a progress report that highlights the significant steps the health system has taken to integrate diversity and inclusion best practices. The office also released the 2022 Diversity and Inclusion Calendar as an educational tool to facilitate common understanding of key diversity and inclusion concepts and terms, as well as highlight cultural and heritage dates throughout the year. In addition, the system fulfilled 1.3 million interpretation requests in over 200 languages and dialects that resulted in more than 18 million interpretation minutes. And furthermore, we expanded workforce training solutions by releasing the first system-level request for proposals for diversity and inclusion training and learning solutions, enrolling over 6,000 affiliate providers in the LGBTQ Health Equity Certificate Program, and launching a volunteer in-house interpreter skills training for bilingual staff. This intensive 16-week course is currently being offered in Spanish with the aim of expanding language offerings in the future. There were also 58,000 trainings completed on diversity and inclusion that include topics such as interreligious awareness, introduction to unconscious bias, LGBTQ affirming services, and health literacy, just to name a few. And there were over 26,000 training completions for Cycle 4 sexual harassment prevention. This concludes my updates, and happy to answer any questions that you may have at this time.
Let me ask each one of the members if there is any questions. Jose, any questions?
I just want to commend you for all the efforts and accomplishments that you have highlighted this morning. I mean, I know it's a lot of work, and I know it's happening in the middle of COVID, and it's just impressive. So let me just say that. Thank you.
Thank you, Jose. Dr. Katz, any questions or comments? I think you are muted, Dr. Katz. We cannot hear you.
Thank you, Fenny. No, I'm just very proud of health and hospitals for the amazing progress staff have made. Thank you.
Thank you, Dr. Katz. Sally?
Just concur, such great work in such an abbreviated time frame under such difficult conditions. Terrific.
Thank you, Sally. I will agree with all the other members. Incredible work and definitely making Health and Hospital a place where our patients feel that they are respected, welcome, and supported. So I just want to again thank you and your team for amazing work and putting everything together, as Sally mentioned, under very challenging circumstances. So thank you, Mateo.
Thank you.
Now we have Dr. Sineas and Dr. Davis, who will provide an update on the Equity and Access Council.
Great, thank you. Good morning, everyone. So I'm
Good
going to be
morning.
good morning. I'm going to be providing an update on our work group. And what we thought we would do in terms of providing updates for the Equity and Access Council is to really be able to focus on one work group at each of our meetings. So today we're going to focus on the Equity of Care work groups. And we have some really great updates there. One of our goals was to include race, ethnicity, and language on each of our chronic disease dashboards. And so now I'm happy to say that all of our dashboards, all 5 of our dashboards now does have race, ethnicity, and language included so that the data can be stratified this way. And those dashboards include depression in adolescents and adults, our hypertension dashboard, our diabetes, as well as our smoking dashboard. We will be working with our facilities just to educate our facilities on how to access the dashboards and how they can utilize this information. And some of those plans are, of course, delayed, being that all of our frontline staff are dealing with the surge right now, but that is planned for the future. In terms of our work on medical racism, as Mathilde previously mentioned, we have already implemented changes in the algorithms for vaginal birth after C-section, as well as for kidney function. We're now focused on monitoring the outcome of implementation of our kidney function algorithm, looking at the potential impact of the change in using the new algorithm for kidney function on clinical decisions. As well as we are looking at future algorithms, we're really trying to find out how we can best eliminate race in our pulmonary function test assessments. So that's future work that will be done. Next slide, please. And another area of work, could you go back one slide, please, is expansion of our sickle cell centers of excellence. So we're really exploring how to expand services so that we can provide an optimal level of care for all of our patients with sickle cell. The reason why we've been focused on sickle cell is Health and Hospitals is one of the largest providers of care to individuals with sickle cell in New York City. We provide care to about 1/3 of adults who have Medicaid and sickle cell, and about 1/4 of children. And sickle cell, as we know, largely affects minorities. So 90% of the patients are of African descent, 10% are Hispanic, and some individuals do come from Indian, Middle Eastern, and Mediterranean descent. Unfortunately, patients with sickle cell are often stigmatized. And unfortunately, there's also increased mortality, particularly around the time of transition from pediatric to adult care. Now, while we have pediatric comprehensive centers throughout our system, what we don't have is adult comprehensive centers. So we only have 2 comprehensive centers for adult patients with sickle cell. Those are located at Kings and Queens. And we're aiming to expand to 4. We're hoping for one in the Bronx as well as one in Manhattan. Exact locations are to be determined. So in our last Equity of Care work group meeting, we reviewed the proposal, and now we will be working on a business plan to be submitted to clinical services planning. Next slide, please. So
Can I just ask a quick question?
sure.
Yeah, just that 1/3 of adults with Medicaid, what does that translate into numbers, if you have the actual numbers?
I don't have the exact numbers, but I can get
Okay.
that to you.
All right, thank you.
Dr. Davis, since we are moving from one area to another, maybe I can ask the other members if they have any questions. Is that okay, Dr. Davis?
Sure.
Okay. Jose, do you have any question about what Dr. Davis presented about the Sickle Cell Centers of Excellence or the e-racism?
No questions, just great work, and thank you for the update.
Thank you. Dr. Katz?
No questions. Thank you.
Thank you. Again, thank you, Dr. Davis. If you wanted to proceed, you can proceed. Yes.
Sure.
Dr. Morse is, I'm sorry, Dr.
Oh.
Morse is on the,
Oh, sorry. Okay. Dr. Morse, I apologize. Do you have any questions?
That's okay, and I apologize for being a few minutes late. I just joined, so no questions at the moment.
Okay, thank you. Yeah, Dr. Davis.
Great, thanks. Next slide, please. So now I'm just going to walk you through a few screenshots just to show you how the data, how we're now able to stratify our data, our chronic disease data, according to race, ethnicity, and language. So this is data that I'm sharing regarding our diabetes control, and our diabetes control rate overall has improved. We're now at 66%. And this screenshot is looking at that breakdown according to race, ethnicity. And as you can see here, you do see that patients who are Asian, Pacific Islander, have higher rates of diabetes control as compared to, say, our patients who are Hispanic. And so this data doesn't tell us why, but it really just starts to have us to ask questions and to really think about where there might be some opportunities for intervention. Next slide, please. When we look at diabetes control rate according to age, we see that the younger population, ages 18 to 44, have lower rates of control of their diabetes when you compare to an older population, say those patients that are above age 65. And I think that this is in the literature, and also can be due to the different type of diabetes that they have. So younger patients may have more type 1 diabetes, which may be a little more difficult to control, as well as just, younger patients and the focus or lack of focus that they may spend in terms of improving their chronic illnesses. It's really hard to be young and trying to manage diabetes. So, but again, so these, again, don't tell us the whys, but it gives us the reason, it gives us, it raises the question and gives us an opportunity to think about how we may be able to intervene for different groups of different subsets of our population. Next slide, please. And when we look at diabetes control broken out by language, again, we see here that our patients who speak Spanish have lower rates of control than our patients who speak Mandarin, right? So this could be not necessarily a result of the language. It might be the practice or the culture amongst those patients who speak the different languages, the communities. So I think what this really allows us to do is to think about how we might intervene better. Or it might be an opportunity to think about, do we need to make sure that some of our Spanish-facing material are, just review some of our Spanish-facing material and make sure that there's more availability. The map to the right actually is a map that, if we were looking at this live, would help us to see the rate of control according to zip code. And so again, this would give us opportunities to think about, are there some zip codes that have lower rates of control that would allow us to think about how to partner better with maybe community-based organizations in those areas, or with Department of Health and Mental Hygiene, in terms of how do we think about working in some communities in terms of improving outcomes. Next slide, please. And this last screenshot is looking at hypertension according to race, ethnicity. And here we can see that patients who are Black or African American have lower rates of blood pressure control than some of our other groups of patients. And again, this allows us to start to think about, are there other opportunities for how we can be thinking about improving blood pressure control in some subsets of our population. So this data is now available in this way to our frontline staff. And each facility, they would be able to look at this according to their facility. So a facility could look to see how their data looks, how their chronic disease data looks according to these stratifications, and can really think about other opportunities for improving their chronic disease control metrics. And that's it for our updates from the Equity of Care Work Group. Any questions?
Thank you, Dr. Davis. I really appreciate the thoroughness of your presentation. Let me go and ask the members of the committee. Jose, any comments or questions?
Just to point out that the ability to slice data in different ways like this opens so many possibilities to live up to our sort of overall goal of related to equity. So congratulations, and I look forward to seeing how this evolves into a tool that can be used on a not day-to-day basis, but close to it, I guess. Thank you.
Thank you, Jose. Dr. Katz? I think you're muted again, Dr. Katz.
No questions, thank you.
Thank you. Sally?
Just a great analytical tool. I agree with Jose.
Thank you, Sally. Dr. Morse?
Yeah, I was also going to repeat, especially as an internist, this is impressive, especially the hypertension data. And I know it's above kind of national rates of hypertension control. I'm relatively new to this subcommittee, so I was just curious if there's a target for blood pressure control that the team's working towards.
Yeah, we've been working towards a 75% control.
Any other questions, Dr. Morse? Thank you. I actually would like to follow in Dr. Moore's comments in terms of the national average. Maybe there is a way to present in these kind of screens that information, so at least we can see how are we comparing or how our patients are comparing to the national average. I don't know if there is information about the state that is available that maybe we can look, because that allows you to have some kind of benchmarking, and of course, if we can put our goal here, it kind of communicates to everybody where we are aiming at, how we are comparing to the state and to the nation. I think that will be useful information. And I just want to say that I want to thank Dr. Davis, Dr. Cineas, and the IT staff, and Eric and Matt, because I don't know if you recall last quarter when we had our meeting, well, actually last month was it, I think, when we had the meeting. No, not last month, November 8th last year. November 8th, we had our meeting. There were none of this dashboard had this information. Okay, so in couple of months, the group with the IT and Dr. Davis and Dr. Cineas leadership, Eric and Matt, made it happen. So now we have all 5 dashboards have this information, and you can see how useful this is in terms of asking questions and providing us for areas in which we can start looking more closely on how to support our patients. And I think this is quite interesting. For example, when I saw this data, a question that came to my head is like how the same group, like for example, if we look at the Spanish speaking, the Hispanic, how they control better seems for this data hypertension than diabetes, and the reverse comes from the Black African Americans. And so it's interesting how certain illnesses or certain conditions are kind of controlled differently by the same group. I think that will be a very interesting question to ask. Are there something that we can do? I can look at what are we doing in hypertension for Hispanic and Latinx. Are there something lessons learned that we can do for the diabetes? I don't know. I'm not a physician, but I'm thinking this opens up some interesting question because we see that in some areas they are doing like better in controlling while in others are not. The other idea, again, when you do a good job, you just get more work. That's the reality of life. This dashboard provides so much interesting information that, when I was looking at the map to the right, and we can see it by zip code, you can imagine that we can now overlay the different stratification. Can we look at by zip code, the Hispanic, Latinx groups, how are they doing? Is there a difference between one geographical area and another in how they are controlling diabetes? And that may be good information because maybe some of the community-based organizations are doing a better job of communicating with the groups and looking, because now we are looking at the group in different locations, that may help to answer some questions and help us to support better. And maybe some of our hospital or facilities in certain area are doing a much better communicating with those groups. So I think this opens up so many different venues to look at the data and to devise intervention strategies that I think is quite impressive. So I just want to again thank Dr. Davis, Dr. Cineas, Eric, and Matt, and the IT group for putting this together. So thank you so much.
Great, thank
Um,
you.
is there any other comments or any other questions?
Fenny, I'd like to go back to
Yes.
sickle cell for just a minute, just
Yeah.
for a couple of minutes. I don't have an extensive knowledge about sickle cell, so I'm curious if I could take a few minutes just to understand better what it is and what the symptoms are and what the prognosis is, just briefly.
Sure. So sickle cell is it's a disease of the blood that causes and it's a genetic illness, and it causes the red blood cells to sickle. They have a different shape, and as they change shape, what will happen is that you can get different types of what's called hemocclusive illnesses. So essentially, you'll get occlusion in some vessels, and some of the symptoms can be the most common symptom that you see is pain, and so patients will have what's called painful crises, and so they will often present in the emergency room or to their doctor with significant debilitating pain that could be brought on. It could have been spontaneous. It could be because they were dehydrated and started working out. And it could be because of they're just going through what's called a sickle crisis. But that becomes the most debilitating symptom. And what happens often is that patients will have repeated episodes of pain, and some of the problem and the stigma is because they may frequently present in what's called these painful crises, requiring pain medication. So they can often get stigmatized as being just wanting narcotics, as opposed to being treated as patients who are in really significant pain and needing relief of that pain. So sickle cell causes lots of other issues. It causes can cause stroke. It can cause obviously severe anemia, and there are other things that it will cause. But I think the stigmatizing part of it tends to be because patients experience really severe pain and frequent the emergency room seeking relief of their pain.
Mm, mm. Okay, and you said that there's increased mortality during time of transition from pediatric to adult care.
Yeah, so what happens is when the children will have sickle cell and they might be plugged into their care with their pediatrician or their comprehensive center as a child. And so there's, can be a lot of support and oversight at that point. And then as they're now transitioning to adulthood and may have to seek out different services, seek out an adult provider, then those things start to change because they can have gaps in their care as one, right? So they might go from not having their pediatrician to now seeking an adult provider. And if there's a long enough gap, then during that period of time, they're accessing the emergency room more. And so they're having less comprehensive, coordinated care. And so they see this as a time of higher mortality due to poor transition planning. So we're hoping that that's something we can really think about how to improve upon.
Nicola, that's really an issue, a developmental issue for a number of diseases, don't you
Yes,
think?
it is. We see it for
For
HIV too.
type 1 diabetes.
Yep.
I think this comes up as well as kidney transplants. I think in general, our systems don't do well for young adults. And that's one of the areas where I would like health and hospitals to get better and better, that there's a cultural competency in the care of young adults, right, who have very high hormone levels, a certain amount of impulsivity, a certain awkwardness between the childhood and the adult stage, because I think there's a lot of dropping out of care, right? And part of our goal is to make places that people feel comfortable. And the traditional, you're a pediatrician, this is a child clinic, you're an adult, this is a middle-aged clinic, just doesn't work for the young adults.
I see. Thank you so much, both of you.
Thank you, Sally. Any other questions from the other members, Jose or Dr. Morse? No?
No, thanks.
Thank you. Dr. Davis, I just want to follow up on a question based on what Sally asked. As we are looking now at these new centers of excellence, the two that you are looking, are we looking at the demographics of where the patients are so that we try to place it closer to where most of the people are in a particular area? Since we already saw the analytics of the map, is that something that we are looking at? And then following up on Dr. Katz's comment, are we looking that these centers have more of support for that transition so that it allows for that pediatrician, physician, the regular physician transition?
Yes, we're really thinking about where putting the sites, according to the volume of patients,
Okay.
And where those centers can be the most utilized. So yes, we're looking at that.
Okay. And in terms of the adolescents, is part of the Center of Excellence to look at that transition closely, or is that something larger that is being looked holistically across the system?
Yeah, I think that's something that we have to look at across the system, but the hope is that it's two different issues. One is there aren't enough adult comprehensive care models for patients with sickle cell. So by creating, 2 more sites, that's going to allow us to have safer transition from pediatrics to adulthood. So it's looking at both of those things in parallel.
Thank you. Is there any other material that will be presented? I think this is all. Is that correct, Dr. Davis?
Yes, that's all. That's it from me. Yes.
Okay. So I think, Felicia, do we know if there is any other, or let me ask the members, is there any old business that we need to cover? any new business? I think this meeting will give you 30 minutes back to your very busy schedule. So thank you, Matilde. Thank you, Beth. Thank you, Dr.
Thank you.
Davis.
Thank you,
you.
Fanny.
Thank you, everyone.
Everybody.
Bye.
See you in
Thank
the next
you.
meeting. Bye-bye.
Thank you.
Bye.
This meeting is adjourned. Bye-bye.
Thanks.
Bye.
Bye.